All right, so now we've got these regimens that we see kill tumor, right? So we've got response rate. So what do we like to do when we've got a good metastatic regimen? We like to move it into the adjuvant setting. So, Francis, can you tell me, there's a clinical trial going on right now? Is that
Yes, and we're just about to be a part of that, and I'm excited about it because I do think it's asking the next question. If something works in metastatic, like you said, will it work in adjuvant? And for everyone that's a medical and surgical oncologist, we all know that those 20 to 25% of the patients that can get a Whipple, we're very happy about because that can interface into a longer survival. But the reality is that only about 5% at 5 years are going to be around. So we really have to ask this question. This is not just an academic question, it's a reality. And the hope is, I think, that Gem/Abraxane could do the same thing as what we saw in metastatic in here. We're just about to start that trial. And I'm excited about it because we need to make a dent in this. For a person to go through a Whipple procedure and have only 5% of the people alive in 5 years, it's really not acceptable.
Yeah, we need this clinical trial done.
Yeah.
So let's say, Ramesh, that you, and this would never happen, don't have a clinical trial available for your patient who's adjuvant. Do you wonder about pulling those regimens into the adjuvant setting?
I think there's a temptation to do that just because of what Francis said. The outcome after surgery, the recurrence rate is extraordinarily high. It's unlike colon cancer or breast cancer where recurrence rates are lower. The reason I would hesitate to use it off a clinical trial is what we have seen in other areas. Colon cancer, we have seen FOLFIRI, we have seen bevacizumab, Erbitux, all fail in the adjuvant setting. So it does not necessarily translate. So we do hold the line and say adjuvant therapy, standard still is gemcitabine off a clinical trial.
Very good. So Gabi, I'm going to make it a little easier for you. So locally advanced. So these are our unresectable patients. We saw some recent data at ASCO out of France that was talking about radiation and erlotinib, Gem/Erlotinib, for locally advanced pancreatic cancer. Can you tell us a little bit about that data?
Yes, so Dr. Hamel from France presented the LAP07 study, which really stirred a lot of discussions and controversy in what we thought we have the question answered. We thought that, we always treat chemotherapy first for 3 months, and if the patients don't progress, we consolidate with radiation. And that has been fairly established based on a lot of meta-analysis data. And then the French group, I think it was maybe a multi-country, multi-institutional study, the LAP07, really answered a very good question. They all started with the hypothesis that we have to give patients induction chemotherapy because we don't want to radiate a cancer that's going to metastasize very fast. So we started out with 4 months of chemotherapy, and that was a backbone of gemcitabine, and half the patients also received erlotinib based on the positive metastatic. So again, inferring that if it works in metastatic diseases, must work in locally advanced. So we did that. We added half and half, gem plus minus erlotinib. And then if there was no progression after 4 months, patients in each group were randomized to receive 5.5 weeks of radiation with capecitabine, or to continue 2 more months to complete 6 months of overall chemotherapy exposure. And the big surprise came, actually it was a twofold surprise. The first surprise was that the radiation therapy did not contribute to improve progression-free or overall survival, unfortunately, not at all. So you were better off continuing chemotherapy than getting radiation. And the second big surprise was that erlotinib, which we have FDA approval for metastatic pancreatic cancer with gemcitabine, was not only not beneficial, but it was actually detrimental in outcomes when combined with gemcitabine, and that was partly due to toxicity and maybe patients having to stop treatment earlier. But again, no benefit from erlotinib with chemotherapy, no benefit from adding radiation if you had a good 4 months of induction with no progression. So basically the core of chemotherapy with gemcitabine was able to confer about a 16 months overall survival for those patients that didn't progress in the first 4 months. But overall, for the all intent to treat population, was approximately 13.5 months. So fairly good results with gemcitabine alone.
So now that you're hiding